Thank you all so much for joining us today and welcome back. It's been a really, really rich discussion so far, and we hope that you've enjoyed the programming. My name is Adrienne Simmons. I use she, her pronouns, and I'm the Director of Programs for the National Viral Hepatitis Roundtable. Our next session will feature presentations about hepatitis C care in state departments of correction in Tennessee, Indiana, and New Mexico. Following the presentations, Nathan Furukawa will moderate a discussion and Q&A. You may submit your questions at any time using the Q&A feature. I'll now introduce our speakers. From Tennessee, we're joined by Lindsey Sizemore, who serves as the Viral Hepatitis Program Director at the Tennessee Department of Health. Prior to that, she worked as a hepatitis C, HIV, and STI epidemiologist at the Arkansas Department of Health. We'll then hear from two guests from Indiana. Deborah Nichols serves as the epidemiologist for the Indiana Department of Corrections and is a founding member of the Indiana Peer Education Program, ECHO. Deb previously worked at the Indiana Department of Health for 7 years, most recently as the Deputy Surveillance Program Director. We're also joined by Brittany, who has 8 years of experience working in viral hepatitis prevention and surveillance. In her current role as the Viral Hepatitis Services Program Manager, Brittany launched a state-funded linkage to care program for Indiana. And lastly, we'll be joined by two colleagues from New Mexico. Dr. Paulina Deming is a pharmacist and associate professor at the University of New Mexico College of Pharmacy. She also serves as the associate director of Project ECHO's viral hepatitis programs, where she helped increase hepatitis C treatment within the New Mexico correction system. We're also joined by Daniel Rowan, the co-founder of Best Chance, an organization dedicated to serving the diverse needs of people who were recently incarcerated. Daniel currently works as a senior program manager for the New Mexico Peer Education Project, which trains both formerly and currently incarcerated men and women to be peer educators. We're grateful to have such a star-studded panel today. And with that, I will turn it over to our first speaker, Lindsey Sizemore.
Hi, thanks, Adrienne. Can you hear me? Can someone confirm me?
Lindsey, your audio is a little bit distant.
Okay, 1 second.
Is that better?
Yes, much better. Take it away.
Okay, great. Thank you so much. All right. Hi, everyone. As mentioned, I'm Lindsey Sizemore. I'm the Viral Hepatitis Program Director for the Tennessee Department of Health, and I'm going to present today about our Tennessee Department of Correction Hepatitis C Care Continuum Analysis. Next slide. So this is a map of the distribution of Tennessee Department of Correction, or TDOC, facilities across the state. 4 of the facilities are privately run by CoreCivic, and 10 are publicly run by the state. As of mid-2022, there were 19,026 justice-involved individuals housed in TDOC facilities, and there is one county to the left with a yellow dot, and I wanted to point out this county because this is the only facility that provides access to MOUD. Next slide. This shows the TDOC population by race as of the 2022 annual report, of which 55% were white and 42% were Black. Next slide. And this is the TDOC population by age from the same report. Over 50% of the TDOC population was between the ages of 20 and 39, so the population tends to be young. Next slide. So this slide shows a brief history of Hep C annual treatment funding at TDOC. So in 2016, the American Civil Liberties Union filed a lawsuit on behalf of 2 justice-involved individuals living with Hep C, alleging their 8th Amendment rights were being violated because there was a cure available for hepatitis C, and TDOC was not providing access to that cure. That year, treatment funding was allocated at $600,000. The next year, in 2017, that lawsuit was granted class action status, and the legislature increased treatment funding by an additional $2 million. The following year, in 2018, the lawsuit was ongoing, and the legislature increased treatment funding to $4.6 million. In 2019, the bench trial for the lawsuit was scheduled, and the legislature made a one-time allocation of $25 million for TDOC to test and treat Hep C for as many individuals as possible. Ultimately, the courts ruled in favor of TDOC, finding the increase in funding for testing and treatment a good faith effort to identify and treat justice-involved individuals living with hepatitis C. Although the court did note if TDOC were to backtrack on these efforts, another lawsuit could be filed on behalf of justice-involved individuals. Next slide. So all justice-involved individuals are tested for hepatitis C upon initial intake, once they're transferred to their next facility, multiple times during treatment, and at personal request if they think they may have been exposed. All hepatitis C RNA positive individuals receive a genotype test, liver function blood panel, and a FibroScan screening to assess level of liver damage. Justice-involved individuals are then categorized based on their level of liver fibrosis and genotype. Individuals who have F3 liver fibrosis are prioritized for treatment. Each month, if there's additional funding available, then F1 and F2 candidates are considered. Within each liver fibrosis group, justice-involved individuals with genotype 3 are prioritized for treatment. And current hepatitis C treatment pricing is obtained through 340B status. Private prisons are not eligible for 340B, and they work with pharma to advocate for better pricing. Next slide. So here we have a figure that depicts the increase in hepatitis C treatment during this analysis period from 2016 to 2021. The first year, we only have evidence of one individual being treated. Treatment ramps up starting in 2018, reaching a peak of nearly 1,000 justice-involved individuals treated in 2021, a significant increase in treatment due to the lawsuit. Next slide. So next I'll cover our TDOC hepatitis C care continuum. So in our diagnosed category, there were 8,911 justice-involved individuals who tested either Hep C antibody positive or an RNA positive, representing our diagnosed group. Next slide. For our confirmed group, there were 7,103 individuals, or almost 80% of the diagnosed group, who were RNA positive and therefore confirmed. Next slide. For the confirmed group, we have 2,183 individuals who went on to achieve a cured status, representing over 30% of those who were confirmed. Next slide. And from the cured group, there were 365 individuals who showed evidence of a subsequent infection due to testing RNA positive after their RNA negative. This amounted to 16.7% of the cured group. Next slide. So to review, the number of cured cases increased substantially from 1 person in 2016 to nearly 1,000 people in 2021. This dramatic increase directly coincides with TDOC's intensive treatment efforts, likely due to the lawsuit. We were curious about the time difference between achieving cure and evidence of subsequent infection, and found that the average time was 253 days, or about 8 months. And so in other words, justice-involved individuals who did go on to acquire hepatitis C again did so fairly quickly. Next slide. We were also curious about the age difference between those that were cured and those with a subsequent infection. We ultimately didn't see a large difference between the two groups, but it was interesting to see the range of those who were cured. On the low end was 23 years old, and the high end was 80 years old, with the majority between the ages of 38 and 55, which really makes sense if TDOC is treating based on liver damage, as we'd expect the patient population to be middle-aged. Next slide. Like many DOCs, TDOC is an incredibly difficult environment to provide resources because most solutions are not allowed. Prevention messaging is essentially one of abstinence. Justice-involved individuals are not allowed to have condoms, needles, or other harm reduction supplies, and only one of the 14 TDOC facilities provide medication for opioid use disorder. On the positive side, TDOC launched a Project ECHO peer education program in January of this year in partnership with the Department of Health. This is a train-the-trainer model that educates justice-involved individuals on bloodborne pathogen transmission and harm reduction strategies. And it will be interesting in the next couple of years after the program becomes established to see if there's an impact on new diagnoses and subsequent infections. Next slide. Last, I'll cover some strengths and weaknesses of our analysis. On the plus side, both RNA positive and RNA negative results are reportable in Tennessee. TDOC hepatitis C labs are performed at a commercial lab, making reporting consistent and reliable. And finally, this analysis includes approximately 84,000 labs from nearly 9,000 justice-involved individuals across the study time period, giving us a robust set of data for our analysis. But of course, there are some weaknesses. First, negative hepatitis C antibody results are not reportable in Tennessee, so we don't know how many justice-involved individuals actually receive testing for hepatitis C. Our analysis relies exclusively on laboratory data and surveillance case definitions as a proxy for treatment, which we know is an incomplete picture of the true status of treatment at TDOC. And because of this limitation, we're unable to differentiate between treatment failure and reinfection. However, based on conversations with our TDOC colleagues, we do suspect that these are reinfections, and we're planning to analyze the genotype results as part of this ongoing analysis. We're also planning to dive more into the weeds on the individuals with subsequent infection in general. Next slide. So in conclusion, the carceral setting provides a really unique opportunity for hepatitis C testing and treatment of this disproportionately impacted population. Our study demonstrated that individuals living with hepatitis C while incarcerated can be successfully cured. The high rate of subsequent infection points to a need for comprehensive and innovative harm reduction to accommodate the limitations in the carceral setting. Additionally, similar efforts can be implemented in county jails. Together, treatment in carceral settings can play a crucial role in Hep C elimination efforts. Next slide. I want to acknowledge Paula Shoup, who's our Director of Viral Hepatitis Core Surveillance at the Tennessee Department of Health. She really spearheaded this analysis but could not be here today to present. Here are both of our emails. And with that, I'm going to turn it over to my colleagues in Indiana. Thank you.
Thank you, Lindsey. Appreciate that. So I am Deb Nichols. I am the epidemiologist at Indiana Department of Correction. And I'm going to speak for a little bit here, and then I'm going to pass it over to my colleague at the Indiana Department of Health, Brittany Gross. She's the Viral Hepatitis Service Program Manager. Next slide. So Indiana Department of Correction, we do have 21 facilities located across the state. 18 of those are classified as adult facilities and 3 are juvenile. 2 are private GO facilities. On average, our adult population is about 23,300 people and about 365 juveniles. The average age of the people that are incarcerated in Indiana is 40. And you could look at some of the demographics here. We have about 63% white, 32% Black, and about 4% Hispanic. And about 1 in 10 people are female, the rest are male. And looking at some intake data, so we do have universal testing on intake. About 23% of those are antibody positive, and that's data looking at 2020 through 2022. Next slide. So what I want to focus on right now is scaling up Hep C treatment in IDOC. So Indiana was one of those states that was sued, and usually we will refer to it as the Stafford settlement. And we entered into a settlement agreement, and we treated everyone with Hep C by July 1st, 2023. And so it was in September 2018 that the court granted the plaintiff's motion for summary judgment, finding the Indiana Department of Correction Hep C treatment policy violated the 8th Amendment. And so we have that agreement, and then an updated one that says all current and future people in DOC custody who have been diagnosed or will be diagnosed in the future with chronic Hep C and for whom treatment with direct-acting antivirals is not medically contraindicated are eligible for this settlement. So we did phase in treatment over time, and basically from April 1st, 2017 to January 19th, 2018, there were 41 people in DOC who had been treated for Hep C. And we started off with APRI scores greater than or equal to 1.5, and you can see the list there. And also our treatment settlement includes anyone who's newly infected or reinfected. So if you look at the graph on the right of the number of incarcerated individuals in Indiana who started Hep C treatment through January 2018, that includes all of January 2018 through June 15th of this year, you will see a gradual or a sharp increase from 2019 to 2020. Then you do see a dip in 2021, and that is where we switched healthcare, our contracted healthcare provider. And that was, we went from Wexford to Centurion, and then you see that subsequent increase. And again, this is only data from 5 months out of the year for 2023. Since then, or all the data in this graph represent almost 5,000 people that have been treated for Hep C within the Department of Corrections. Next slide. And so we did also look at a Hep C care cascade. I want to thank an intern who was here over the summer, Min2, who did this care cascade by hand. So this is doing medical record searches within our electronic medical record. It represents 8,459 people that had an intake, lab, or they were a parole violator. And so they were included in that this care cascade if they met that criteria. And what you'll notice is that we had 100% antibody testing for this group. Again, it's intake and parole violators. And then if you look at the RNA, unfortunately, we did have some missing RNAs. Sometimes people were released before we got that RNA test, or they ended up refusing that second blood draw for some of the reasons that are listed there. Treatment. We had 84% of that group that had started treatment, and reasons for not starting treatment include that they were released, or they were contraindicated, or they refused. And again, we have a whole plethora of reasons for refusal as well, and we do document all of those. And then if you look at the first follow-up after treatment was completed, you can see that we had 52% that were negative at that 12-week mark. We had a 3% positive that represents 24 people as a treatment failure or reinfection. And again, all of those parts in blue are opportunities for us in Indiana to follow up with linkage to care, especially as people are being released before we have follow-up. Next slide. Okay, so hepatitis C testing and treatment. So again, we do have a universal opt-out Hep C screening that is conducted at the intake facilities and is run by our Department of Health lab. Unfortunately, there is no reflex testing at intake, and it does require a separate blood draw that is taken by the contracted health provider and sent to Garcia, is the lab that they use. Added in June of 2022, we did add a once-a-year option for an annual Hep C screening. So they can get that during their annual exam, and no risk factor questions are asked, and there's also no copay if that once-a-year screening is done during the annual exam. Unfortunately, if it's done any other time, there is a copay associated with that. So treatment, everyone is eligible, and anyone who has started treatment will stay in chronic care until SVR is documented. If they are released before treatment, then they are considered a special needs release, and they work with our transitional healthcare team. And I said before, reinfections are eligible for treatment. Next slide. And so what are we doing in Indiana DOC for education and funding? So Indiana also has a peer education program. We rolled it out in 2019. It is a replication of the New Mexico peer education program. We are in 9 facilities now, and we've done about 17 40-hour trainings. We have 2,500 individuals who have done the 10-hour workshops by the peers, and we've trained 276 peer educators. As far as funding for the Hep C program, it is mainly through the Indiana budget. The treatment costs, so it's an allocated line item on the DOC budget, and we do utilize 340B pricing to try to get discount pricing. We do have an in-kind MOU between Department of Correction and Department of Health to sustain that 340B pricing and the regulations with that. The testing, the intake testing and parole violator screenings are paid for out of Indiana Department of Health's budget. And then everything else, so provider fees and all of that, are through our contracted health services. Next slide. And so I mentioned before, so we have our physical health program at DOC, but we also have a transitional health service program. It was expanded after the Hep C settlement, and it will ensure activation of benefits. So all of the transitional healthcare workers are working to make sure everyone has Medicaid as soon as they leave the facilities. And also, if people are not treated in DOC, again, they're considered special needs, and they are prioritized for the transitional health services. So with that, I would like to pass it over to Brittany Gross at the Indiana Department of Health. Thank you.
Hi, everyone. I'm Brittany Gross, the Viral Hepatitis Services Program Manager with the Indiana Department of Health. And like Deb mentioned, we do work very closely with our Department of Correction here in Indiana. So after the settlement was created, we worked very closely and collaborated with them. And in 2020, the Indiana Department of Health was able to launch the Viral Hepatitis Services Program, which was a hepatitis C linkage to care program. And so that transitional healthcare team makes referrals to that viral hepatitis services program. And initially, that transitional healthcare team was referring to the 4 or 5 different sites and the different care coordinators across the state. But we realized that was really challenging and complicated for the transitional healthcare team to keep up with. And so in 2021, we restructured the program and established a DOC hub care coordinator. And that allows the DOC hub care coordinator greater access to work with individuals and better communication. And we'll take a look at that a little bit more as we go on throughout the presentation. Next slide, please. So we started out with our viral hepatitis services program in 2020, but Indiana was granted American Rescue Plan Act funding in 2021. And our state decided to allow these funds to go towards addressing specific health issues and challenges through a grant process that was directly to go out to the communities that needed it. And the Indiana Department of Health was to oversee these grant funds. And hepatitis C was one of the top topics included in these grant funds, as Indiana ranked #1 in the nation for reported acute cases in 2018 and 2019. So Connect to Cure was born, and basically it utilized the process and the structure of the existing Linkage to Care program, or the Viral Hepatitis Services program. Only one major difference was that when we built out Connect to Cure, we leveraged our Zero as Possible plan, Indiana's plan to end HIV and hepatitis C, and worked with our established ZIP coalitions, which came out of our Zero as Possible plan, to gather input on where to place these care coordinators across the state. So this was very much locally driven. And now we have 20 care coordinators across the state, 21 sites. We also were able to place a tester/peer in each ZIP coalition. We have 10 ZIP coalitions across Indiana. And all of our linkage to care efforts are known as Connect to Cure. Next slide, please. And so on the slide, you can see some of the things that Connect to Cure aims to do. One is that it creates a community of practice for all of these new care coordinators working across the state, as with this is something that we did not previously have in our state. And it also aims to assist those living with hepatitis C through those things listed on the slide here, such as having that additional testing capacity, telehealth, RNA testing through dried blood spot testing, insurance navigation. We established HepMap, which is a medical assistance program, and nutrition and transportation assistance cards. Next slide, please. So how do we get folks to this Linkage to Care program or Connect to Cure? We really work to put the care coordinators' information out into the community as much as we possibly can. And we really believe that it works best if we allow individuals that are ready to address their hepatitis C to contact those care coordinators when they're ready. So you can see on the slide that we have a website for Connect to Cure. It's www.connecttocure.org. There is a typo on the slide there. We did have a previous Ask and Act campaign that does link to Connect to Cure now, and you can also access it through the Indiana Department of Health website. And again, providers, community-based organizations, partnerships, all can link to Connect to Cure. They can make referrals, but we really just encourage providers to give out the closest care coordinator so that they can, again, so that folks, when they're ready to address their hepatitis C, can contact that care coordinator. Next slide, please. But we realize for individuals that are still residing in a Department of Correction facility that that is not a feasible option. And so this is one of the great benefits of having our DOC Hub Care Coordinator. That DOC Hub Care Coordinator when we were able to restructure our program and give this access to that one DOC hub care coordinator, was granted access to GTL, which is like email for the Department of Correction here in Indiana. And that DOC hub care coordinator is given a list of individuals that meet the qualifications for this program about 90 days prior to when they're going to be released. The hub care coordinator can communicate with those individuals via GTL or email. And individuals can either respond to that message. If they respond, they get education on hepatitis C, the program, and they may even choose to enroll just through those email communications. Or they may not respond at all. They may say, I don't know who this is. I don't want to talk to you. Either way, at the end of that process, our DOC hub care coordinator then will transfer information, basic minimal information, to a more regionally based care coordinator to where they will be residing post their DOC facility residence. And so that's really what we have for you from Indiana. I believe our next slide is our contact information. We will be happy to address any questions that you have for us. And at this point, I'm going to turn it over to our colleagues in New Mexico.
Hi, thank you so much. This is Paulina Deming. I'm one of the directors for the viral hepatitis programs here at ECHO, and I'm joined by Daniel Rowan, who is the operations director of our peer education program. So he'll talk a little bit more about that in just a minute. And next slide, please. So historically, New Mexico has had a high prevalence of hepatitis C in our state prison system, here at 41%, according to published data. Next slide, please. And unfortunately, New Mexico, as a state, excuse me, as a state in general, has had a high burden of Hep C infections, as well as Hep C associated mortality. And this is really what helped prompt Hep C treatment within our prison system as well. Next slide, please. The New Mexico Corrections Department has 11 prisons across the state of New Mexico, denoted here in these red dots with the white cross. Historically, we know that that this prison population had a census of about 7,000. It's lower currently, and antibody prevalence upon anti-Hep C prevalent antibody prevalence, seroprevalence, positivity upon entry was approximately 50%, and unfortunately, viremia rate was approaching 40%. So again, this sort of mimicked what we were seeing in the state in general with a high Hep C disease burden. So this prompted this collaboration between the Corrections Department and Project ECHO. Next slide, please. A couple of key timelines are important in understanding the ramp up of Hep C treatment in the state. Notably, 20 years ago, so in 2003 is when we began the collaboration and began treating patients at that time. Approximately 50 to 100 people ultimately were treated during this time point with the interferon therapy. By 2009, the peer education program was started, and that was again to really try to address some of the Hep C misinformation and provide better knowledge about Hep C in the incarcerated persons in the state. And then finally, in 2020, there was a major ramp up, and this was due to the state legislature appropriating over $20 million for Hep C treatment, coincided also with the 340B pricing made available for direct acting antivirals. And at that time, the ECHO program here collaborated with the New Mexico Corrections Department and its medical provider, which is Wexford Health Services, to really ramp up treatment and increase the number of patients undergoing Hep C therapy. You'll note that we actually did not face lawsuit to ramp up our Hep C treatment efforts. Next slide, please. One of the first initiatives, of course, was to revise and work with the Corrections Department in developing their Hep C screening and treatment guidelines. Next slide, please. Subsequently, the treatment approach is universal screening for everyone. with reflex RNA testing. Those that are found to have Hep C viremia undergo baseline laboratories similar to the simplified treatment algorithm from the American Association for the Study of Liver Diseases. They also receive transient elastography. These results are reviewed on a weekly basis by the ECHO faculty, including the elastography results. And then on a monthly basis, all lab data is reviewed of known individuals with hepatitis C, again, to identify patients who may have more advanced liver disease. Next slide. The main point of the review of the labs is to really identify, again, patients who can be treated according to the simplified algorithm, but in particular, who should be presented to ECHO. The goal, of course, is to get as many individuals treated according to the simplified algorithm as possible, but recognizing that there are some patients who require more advanced review, maybe additional management. So basically anyone with cirrhosis, whether it's compensated or decompensated, or any major medical comorbidities, which would prevent them from being treated according to the simplified algorithm, or those individuals who may be on any medications that have major drug-drug interactions, are presented to ECHO for guidance and recommendations on management. Everyone else, if they don't meet this particular criteria, then are treated according to the simplified algorithm by the medical provider on site, and again, follow the simplified treatment approach as per AASLD. Next slide. So the effect that this has had on treatment has been a significant increase. Previously, we were treating about 50 to 100 individuals per year. In late 2020, the treatment ramp up really began. And at that time, you can see the number of patients starting treatment really it increased dramatically, at least 600 patients, up to 800 per year. We have not finished looking at the number of patients who will undergo treatment, of course, for 2023. Expect that number to be close to 800 as well. Next slide. As far as who's being treated, the baseline demographics of predominantly it's male population, primarily again 30 to 40 years of age. We also have a sort of a younger patient population in our prison system. We have a small subset of patients who have cirrhosis that are undergoing treatment. And again, this is I think reflective of more of a simplified treatment approach at this point, where we are able to treat more individuals. Up until about a year ago, we were doing genotype testing. And again, the majority of the patients who underwent Hep C treatment, the genotype 1, but a large proportion also of genotype 3. And that is not unusual. That is what we have seen in the New Mexico prison system for some time, with a high prevalence of genotype 3 infection. Next slide, please. So this table, I think, is remarkable in that it illustrates the impact and ongoing role of ECHO in this ramp up. As you can see, prior to the treatment ramp up in late 2020, all the patients that were starting Hep C treatment were those that had been presented to ECHO here in this turquoise color. And then subsequently, with the revision and guidance, the use of the simplified algorithm, we really increased the number of patients treated by the medical provider that did not require presentation to ECHO. And yet we still, at ECHO, do hear cases on a weekly basis of those individuals that perhaps require additional or closer look prior to treatment start. But again, the overall impact is a substantial increase in the number of patients who are undergoing Hep C treatment. And the success of this, I think, is really due to the collaboration, but also to the role of the peer education program. And I want to hand it over to Daniel to discuss that. Next slide, please.
All right. Thank you, Dr. Deming. Yes, it's my pleasure to talk about the New Mexico Peer Education Project, which a couple of people have mentioned already, also referred to as prisoner health as community health. We say that prisoner health is community health because, as we all know, over 90% of those folks who are incarcerated will be returning back to their community. So it's important that we look at getting them as healthy as possible before release. As you can see, New Mexico it's a large landmass there, and we've got 11 prisons scattered across the entire state, and we do have peer educator groups in all of those facilities. And so you might be wondering, how do you get peer educators into those prison facilities? How do you get them trained? And as we go to the next slide, you will see our 4 components. And while I don't have a lot of time to go through each of these components, I will focus in on the 40-hour training and the 10-hour peer-to-peer workshop. And probably one of the best ways to get an idea of what peer education is to look at it. And you will see in this next slide that we have a couple of different pictures in there. And so I asked the question, how do you get peer educators in a prison? Well, you do an in-person 40-hour training. And at the end of that 40-hour training, you have a group of men or women, depending on the prison, who are ready to go and educate their peers. So we have a graduating group at the top right, and then just below we have a group that is actually educating their peers. You can see them there. They are engaged in health jeopardy that they are facilitating. We use the 5 questions to break down complex medical information so that the peer educators are able to communicate that. In the New Mexico prison system, the average literacy is around 8th grade, so it is taught at that level. And those 5 questions are really helpful with that. We educate very strongly on hepatitis C testing and treatment, and in the hopes of preventing reinfection. But hepatitis C is not the only topic that our peer educators train on. They also train on addiction, sexually transmitted diseases, diabetes, skin infections, and even connecting to resources upon release. And if we go to this next slide, this picture, we share this, it really captures the essence of peer education, which peer education really is an innovative and cost-effective way to provide vital health education. But it's also a way that you can empower folks who are marginalized and typically don't have a voice in their everyday life. If you look at this picture, every single one of these men has a smile on their face. And this is a level 3 facility, which is it's a pretty serious facility, and people don't typically go around smiling. But this really captures the essence of peer education through the 40-hour training, and that they find joy and service to others. And the individuals that go through their workshops find joy in learning. Supporting these 11 groups across the state is challenging. And as we can see in the next slide, the way that we do that is through the use of the ECHO model. So leveraging technology. Twice a month, we come together to do case-based learning, as well as didactic learning to provide continued support for our peer educators. I don't have a picture of it, but now that COVID-19 is, we're past that, we're able to go back out to our facilities. If it wasn't for the ECHO model being in place prior to the pandemic, I'm not sure what would have happened to the program, but we were able to remain operational throughout the pandemic because we had these virtual infrastructure already in place. Next slide. I think that we can all agree that peer education is absolutely critical. One of the ways that we have really been able to enhance our peer education is we ensure that our peer educators who have hepatitis C are able to get treated for hepatitis C. So it truly is peer education so that they can truly speak from a personal perspective about hepatitis C and treatment, and really coming from a personal perspective about the high risk of reinfection and how to prevent it. We have something, it's not in this slide, but we have something that's called the 3 Ps of working with prison medical, and it's using patients' persistence and professionalism. So our peer educators are training their fellow peers on that so that they know how to talk with the providers, and they even help coach them around what questions to ask, so that they can have a clear understanding of what is going on. Peer educators really play a vital role in encouraging folks who have refused treatment to reconsider, and then also, of course, encouraging people to explore healthy alternatives to things like tattooing and drug use. And if we could go to the next slide. There's a number of challenges, of course, in a prison setting, and some of those have been touched on. I would say that peer education really is a way to provide a path forward for individuals, for the peer educators themselves, and also for the students that go through their workshops, a path forward to a healthier and a better life. I had that opportunity myself as a peer educator and discovered that I could have a voice and make a positive impact in the prison system. And that really it's the folks who are incarcerated are closest to the problem. And if we provide them with the appropriate resources, then really they can help us address some of these challenges, such as people who refuse doing the treatment for a number of different reasons. Also challenges around the SVR labs, people not wanting to go back to medical to get that done. And then also the challenges around reinfection that occur in a setting where harm reduction is a real challenge. And speaking of challenges, there are some challenges with working with a private medical vendor that Dr. Deming is going to comment on.
Sure. So, the main, I think, challenge that comes from the clinical side is that we do provide recommendations on Hep C treatment. We are not on site. So that is, I think, an ongoing challenge. Similarly, what we are dealing with now more and more is linking to care upon release to really try to get people the treatment that they need. Next slide, please. Just to summarize, I think the New Mexico Corrections Department collaboration with ECHO and Wexford to do this Hep C treatment is really, I think, a unique collaboration, and some key components, of course, are the universal opt-out screening at intake, but also the low barrier to treatment. So really utilizing that simplified treatment approach to getting people Hep C therapy. At the same time, maintaining the ECHO clinical case sessions so that there is guidance on cases that may be more challenging, more difficult to treat. And this allows for the patients to be treated on site, does not require patients to get sent out for consultation. So again, I think that helps to provide a more comprehensive approach to treatment. And then, of course, the peer education model is really essential to the success of this effort. And finally, the reality is that the national Hep C elimination cannot be achieved without coordinated and aggressive treatment and prevention approaches inside prisons. And I think we're doing our best here in New Mexico. And thank you for your attention.
Great. Thank you so much, Lindsey, Deb, Brittany, Paulina, Daniel. It's so great to hear about all these really innovative approaches to using data, strengthening linkages to care, and peer navigation. I wonder if we could pull off the slides and then highlight or spotlight rather our panelists so we can pull together for a discussion. As part of this discussion, we have also invited some hepatitis C and correctional health experts to be part of this conversation. And I wanted to give them a chance to either pose a question to the presenters or also share any reflections that you might have about what's really important for us in this audience to know about scaling up Hep C treatment in DOCs. So for those of you who are SME participants to pose a question, pop on your video and we will spotlight you, and then be sure to please introduce yourself first. You're also welcome to stay on and be part of this larger conversation. So while I let folks think about questions, maybe I'll start with one. So, in hearing about all of these different activities and programs that you set up, it's been really clear that no one group can do it alone. And in fact, it sounds like you had to navigate a lot of different stakeholders and cultures to get your programs up and running. For the panelists, I'm wondering if you could mention just what it's like almost having to code switch to navigate the various stakeholders to get them to buy into your vision of enhancing Hep C elimination in corrections, and what made your collaborations work?
So I can start just because I went first, so I'll start. I think, first of all, seeing what you have. So, of course, we knew what data that we had to build this care continuum, right? But we also had to tread very lightly there because we knew how we could interpret the data based on how we typically do care continuums in Tennessee. But, that reinfection, subsequent infection data is really striking, right? And so we needed to be careful how we presented that and really get buy-in from our TDOC colleagues to make sure, does this make sense to you? Is this what you also suspect is happening? What are your insights for this? And so really, again, kind of looking at the data that we have to use data for action, but then figuring out who our colleagues are and were in the Department of Correction, but also just being really intentional to really look at them as the subject matter experts, because they are, right? We had to do a lot of listening before we did a lot of talking. And I think sometimes we're really bad at that, to be honest. And really in building these partnerships, you don't know everything, and you need to have them talk to you and kind of explain how things are going boots on the ground in their facilities, and then work together to then kind of interpret what's going on and make a path forward together would be my advice.
Okay, I can go next since I was number 2 on the roster speaking. So yeah, definitely using that data. I am in a unique position to where I came from the viral hepatitis world in my role at the Indiana Department of Health before coming over to correction. So in my role over there, our program made sure that we found out who the champions were. So when we're talking about starting the peer education program, and then how are we going to set that up? So for us is it's probably going to be the same answer. Inside corrections, you're going to need a champion, and make sure that you have more than one in case one leaves. So making sure you're building up that group of supporters for all of it. Again, Indiana had that litigation, so that kind of forced the hand on Hep C treatment, which luckily now it is universal Hep C treatment for anyone who who wants it and it's not contraindicated. So using the cost savings as well. So making sure that who are you talking to? Are you talking to the commissioner? You're going to have that different conversation when you were talking about code switching. Most of those conversations are going to surround money. How can we save money? But then also all along the line of making sure that we're keeping the mission of corrections at the forefront, which is, safety and operations, but also not letting medical and health services just kind of fall to the wayside. The other thing too is making sure that when we're doing any programming or implementing anything, that we're listening to people with lived experience. So talking to people in the facilities that are currently incarcerated or people who have been released, make sure they're at the table for that. Brittany, did you have anything to add?
I would just add that, both you, Deb, and Lindsey have said this, but I think we really need to listen, because when we were working on building this linkage to care, they're coming from DOC to our care coordinator. We were asking, DOC staff to do something more, right? And our hub care coordinator continues to, right? From 2020 when we started to now, continues to make little shifts in what we're asking to make sure that so that we can define that, refine it, make sure that we're not asking them to do more than they're capable or just adding things that would be nice for us, but is, again, above and beyond what they have time to do. And so again, it's working together, but you have to listen and be fully partners in that work.
I had just a little bit to add. I love what everybody has already said, especially with the listening and understanding the perspective of security in a prison system, which that can be a challenge, and it's annoying times with restricted movements and lockdowns, but it's just a reality that has to be in place. As you know, as far as code switching, it's been a really interesting journey for me working full-time for ECHO over the last 5 years. Being a former inmate, going back in, talking with inmates, speaking with wardens, speaking with unit managers, and then coming out and speaking with medical providers and the doctors here at ECHO. And I think just in general, something that's really helped our program and the relationship that we've had with our corrections department is that when we say prisoner health is community health, I reference that individuals who are incarcerated are going to be getting out. But another part of that community that we train the peer educators on is the prison staff and administration, and that they are a part of our community as well. And that we not only care about inmate health, we care about the health of everyone who is in the prison system. And that includes security, that includes administration, that includes the wardens and the deputy wardens. And for myself personally, when I carry that attitude with me into the facility, the folks who are incarcerated there, everyone in a prison is really good at feeling out if you're genuine or not, both staff and inmate. They're very good at reading people, and they're going to read if you're full of it or not. And so for me, and I think for our program, truly caring about the entire community, breaking down that us versus them on both sides while respecting both sides has been a really key component in building the relationship as we do build advocates across the state, prison to prison. And one of the things that's really helped us build advocates in each of the prisons are the peer educators themselves. When unit managers and prison staff see individuals who are passionate for service, they tend to want to support those types of programs.
Great. Thanks all for those, your responses to that question. To our subject matter expertise participants, what questions or thoughts or reflections do you have that you might want to share? I see Matthew has come off mute. Go ahead.
Nate, I've got a question for the New Mexico team. Thanks so much for your amazing presentations. I'm a clinician, infectious disease clinician researcher in New York at Albert Einstein College of Medicine, and I've been active in the advocacy space. And there are two of the presentations presented on sort of litigation-informed initiatives, but New Mexico's presentation managed to, not to get the $20 million appropriation. I was just wondering if you can comment on how that happened, because I think that feels like a bit of a holy grail for people to be able to get these systems online, and something that a lot of states and jurisdictions would be interested in doing.
Thank you for that question. It really started back in 2003 with the launch of the ECHO project in general. And at the time, again, I think recognizing the Hep C epidemic in the state, and that the prison population, of course, is part of the state. So those initial conversations to engage the prison system in collaboration and improving the healthcare system, I think were instrumental. And an ongoing relationship, as Daniel mentioned, to be sort of respectful, but a relationship started many, many years ago. So by the time the DAAs were approved, there was already that relationship in place. We didn't get sued. There was, of course, a lot of, the writing was on the wall that it was coming. And so I think it was that engagement of like, this is what, we need to continue to evolve. We need to ramp up the treatment. I think that's really where it came from, but it came again, from the baseline, it was really the relationships were developed at the beginning and recognizing that this was a state problem, this Hep C epidemic. So I don't know that there's a magic bullet. It was a lot of discussions, a lot of meetings, a lot of collaborative meetings, seeing what can be done, recognizing that something had to happen and trying to figure out where we could make baby steps, which ultimately led to this leap in 2020 with the appropriations. So I don't know if I really answered your question, but it's been a long time in collaboration.
No, you did. Thank you so much. And Adrienne flagged, we recently published a white paper, myself and Tessa Bialik from University of Michigan, on basically policy recommendations and best practices for different jurisdictions that are along various stages of the litigation cascade, I'll call it, for lack of a better term. But it does outline some of the history of litigation. I think Adrienne just posted in the chat, and some best practice policy recommendations for systems who are in the process of scaling up their testing and treatment initiatives. Thanks for posting, Adrienne.
Thanks, Matthew. I saw Risha come unmute. Oh, Amy, did you have something you wanted to respond to, or do you want to let Risha go?
No, please let Risha go.
Okay.
Thank you so much. I'm Risha Irvin, an associate professor at Johns Hopkins in the Division of Infectious Diseases, and have partnered with corrections here in Maryland and in Delaware, training providers, and then in Louisiana on their hepatitis C elimination project, and now working on the national initiative under Dr. Francis Collins. I just wanted to commend all of you kind of on this work, listening to the presentations. I was just so excited about where things have come, because traditionally we haven't had a lot of Hep C testing and treatment in corrections, unfortunately. So to see this work going on in justice-involved populations, it's just really exciting. And I think, you know, an acknowledgement, one, that this is obviously the right thing to do when we have a cure, but also as we try to reach hepatitis C elimination goals to improve morbidity and mortality, we've got to go to the places where we haven't been doing testing and treatment, and that is in justice-involved populations. So again, just want to commend you on the work. I think as we, you know, touched on in the presentations, and what Matthew touched on in terms of a lot of the advocacy and lawsuits that had to happen, because many of the correctional systems, the financial cost of both the medications and then to, you know, training providers or their contracted systems, that was a lot to bear for those systems. Fortunately, some of that price is coming down, but did want to just, again, highlight in terms of the National Hepatitis C plan that one of the parts of that is that there would be a federal procurement of drugs for corrections. And so that cost wouldn't be there anymore. The other part that I do think that's important in the National Hepatitis C plan is training of additional providers, because in many states, they actually don't have enough people to actually treat. So that's also a barrier, whether that's internal or it's through a contracted provider. In your presentations, the things that came up for me were, again, the importance of harm reduction. And I know in the first presentation, you're still teasing out some of that being reinfection versus treatment failure. But I think, again, a signal that how important harm reduction is. And so seeing that, you know, medications, MOUD was only available at kind of the one site. I think it's something for us all to think about, and kind of how those things can be scaled up, and another point of advocacy. Another thing that stuck out to me is where testing is being done. And so obviously really important on intake, transfers, exit. But as we think about kind of moving into correctional populations, how do we test everyone that's already in the system? And so was excited to see that Indiana had that option of testing kind of each year as well, which I think was very important. And then I think the next frontier, it's been great to hear about the state correctional facilities, but where do we go with jails in terms of the rapid turnover? And so, you know, if any of your states are doing anything there, would love to hear anyone touch on kind of any of those partnerships, or kind of anything that you've seen kind of work as we think about all of justice-involved populations. Thank you.
So I can talk a little bit about jails. So this presentation that I gave, we also gave this presentation at CSTE, along with the presentation about some work that we had done in a particular county jail. And And so just kind of acknowledging all the things that we all know, right? Like that folks are kind of in and out, and that it's really hard to ensure kind of continuity of care in that setting. I mean, we all know that. And so we really wanted to conduct a pilot with a willing jail in East Tennessee, which is where we have a lot of our hepatitis C cases concentrated. And so we were kind of just brainstorming how to do that. And where we landed and what we ended up doing was we took a Department of Health nurse and kind of incorporated her into the jail. So she reported to the jail every day. She was there. One, I think that was so important just to kind of get your finger on the pulse about like how things are actually working in the jails, because we're not in there. We have no idea. I mean, the turnover, all those different kinds of things. And she, you know, we had an idea going into it that we were going to just like mass educate everybody and do all these different things. And once she actually got in there, it was like, that was not really possible just because of the way things were laid out and structured and how people were grouped together. And anyway, we learned a lot, but she also was able to kind of jump in and assist with testing as needed or other duties. But really the focus of having her in there was, one, to provide test results and post-test counseling and education, but also to link to care upon release. And so we actually partnered with a local FQHC, but also realizing that individuals should be able to choose where they want to seek care. We also had other options like our health departments that were treating. And so really her focus was, as individuals were getting, well, first of all, as they were getting tested, to give them the appropriate counseling, but as they were getting released, to really try to link them to care then. And again, we did that for 6 months. I would say it was pretty successful. We did see several people that actually were treated, but just a kind of a creative approach to ensuring that, one, we were helping to, you know, helping with the turnover and the short staffedness of the jails by having someone there that could jump in and help and be boots on the ground, but also someone who could really focus on Hep C linkage and harm reduction messaging.
Debbie, again from Indiana. So yeah, we have one jail I know that is offering Hep C treatment, and it's not always consistent. But one thing that we have recently rolled out, so we have our Indiana peer education program, again, that was modeled after New Mexico. We also have what's called an OutPEP program. So it is peers who were trained in the facilities and have now been released, and now they're hired at our partner or community-based organization partner. And so they've signed contracts with some of the local jails to do that same programming at the jails. So they're getting all of that harm reduction information. They are talking about Hep C. They are talking about, you know, what do you need to do? What do the tests mean? What does linkage to care? What if you do go to DOC? What are your steps there? What can you look for? And what questions to ask? And also learning how to be your own patient, your own advocate, starting from that jail level, moving all the way up through the DOC system. And Brittany, I don't know if you have anything else to add about jails. That's all I know at this point.
Yeah, I was just going to add that in Indiana, which I'm sure this is not unique, our jails are operated at the local level. And so each jail, even though every prison operates very, you know, uniquely, each jail very much operates uniquely. And so building something on a larger scale is quite challenging from a big picture standpoint, because we would have to go to each county here in Indiana, and there are 92 of those in Indiana, to kind of build something that was consistent. So that is currently the challenge with our jails.
Hi, Daniel here in New Mexico. We have a similar program here in New Mexico where we employ former peer educators, and we do virtual programming and virtual peer support. And hepatitis C testing and treatment is something that we continue to focus on and promote. We also, in Albuquerque, which is one of our larger cities in the state, have done table events where we set up a table outside of probation and parole and provide essentially brief moments of peer support, encouragement. We even give food, make food, breakfast burritos, and have coffee and cookies. But we've also partnered with one of our local medical providers, Truman Healthcare, and we've actually had the testing van right outside of probation and parole before with incentivized testing. And so we're hoping to continue that as well. We're also looking to, the majority of our peer services are virtual. We're looking to expand that in person, and a number of the locations that we're looking at using, because we think we'll be able to find space that's free of charge, is the Department of Health locations, which again would give people access to that testing and treatment.
Great, thanks. Can we circle back to Amy?
Hello, everyone. I'm Amy Kravietz. I'm Chief of HIV and Hepatitis for the state of California prison system. And we have an enormous population. It was as high as 126,000 back about 6 or 7 years ago. And now we're about 95,000. So still quite a huge population. And we've treated a massive, absolutely massive number of hepatitis C. And at this point, we're in the chasing your tail part of the problem. And I was just wondering, just wanted to know, we've all talked about harm reduction. I know Minnesota has started a, clean tattoo peer program to teach patients how to be an artist, that they can take that skill on the outside. And they've dealt with custody, gotten buy-in for counting the, the needles and everything. And I was wondering if any of you have had any successes in any of the realms of harm reduction, made any headway into the resistance that there is culturally, legally, custody wise. And as a kind of an adjunct to that, we have a lot of politics for our MAT program. And so we are finding it to be an enormous barrier to treating the root cause of HCV, because there's all this politics that are preventing the patients from achieving MAT, and allowing it to, even if they start it, they end up having to quit it because of political pressure on the yard. So kind of a big topic, but I want to know what's happening out there so I can keep pushing in California.
I can go ahead and start. I got you, Lindsey. So the closest we think that we have to, materials provided at Department of Correction is upon release. Unfortunately, inside the facilities, we have not been able to make any headway of any of those kind of fantastic harm reduction training. We've talked about it, the peers. We hear on the ground that, let's have tattoo shops in prisons, then maybe we'll have some of that harm reduction. Regarding MAT, I am not the best person to speak about that for DOC, as the EPI, I just kind of have dabbled in it. I've only been over here for about a year. I do know that patients that come in on Suboxone can stay on Suboxone, and that there are discussions and looking into our healthcare service directives of expanding MAT and MOUD. So more to come on that.
Okay, so we can speak. Oh, sorry. Briefly from New Mexico, I was just going to say that as part of our, we have regular meetings with our with the corrections department and with the medical provider to review patients who are for reinfection risks and what's going on, sort of checking on the program. And noted, of course, that there was of the patients who were reporting reinfection, a large portion of them were reporting tattooing as the risk for reinfection. So it actually prompted more discussion in terms of what could be done. And Daniel?
Yeah, some of those conversations have revolved around having a tattoo program very similar to a barbershop program, have that piloted in a facility. On a practical level, some of the things that we do is like encouraging people not to get number 0 haircuts with the hair trimmers. Do a number 1, number 2. ensuring people use their own razors for razor fades. And I have encountered people that and make sure that they have their own tattoo equipment and then they don't share it. Of course, New Mexico doesn't have harm reduction with clean syringes yet, but New Mexico is looking to pilot in several facilities expansion into the medication assisted therapies.
But to the point of that, I think, because we were even asking the question, we knew that that was a risk, so we could take it back and say, hey, this is what's happening. This is clearly a problem in terms of our treatment initiative. So we have part of the case report form for patients is to track against what the risk factors may be. And we have been surprised at how honest most of the responses seem to be.
So,
I see your colleague Laura is here. Go ahead, Laura.
Can you hear me?
Yeah, go ahead. Please introduce yourself, and then we're either asking questions. It's also a space for you to offer any reflections or even put pressure on those of us at the feds about what we should be doing in this space. Go ahead.
Yeah, so my name is Laura Strick. I'm an infectious disease physician, and I've been working in corrections over 20 years now, and I'm employed both by University of Washington, but also by Washington Department of Corrections. So I just came from a national meeting in Salt Lake City for correctional physicians, and actually I heard about 3 states that are currently looking at setting up their own kind of regulated tattoo shops. We had thought about that about a decade ago. There is literature that came out of Canada that had set up a tattoo shop in one of their prisons. It did not succeed, but the main reason it didn't succeed was because they tried to set it up that it would be self-sustaining by the cost of the tattoos to the population, and they felt that they did not charge enough per tattoo was the reason it did not succeed, but not related to its harm reduction or the actual tattoos. I have partnered with a community-based organization called the Hepatitis Education Project to actually implement a harm reduction program throughout our system. The reality, it takes a lot of education. It's a very different culture in prisons and jails than it is in the community. And it took me really setting up a meeting with all of the superintendents throughout the state. And it just takes one person in that meeting who has a friend or a relative who has died of hepatitis or overdose to really get people's attention and to talk to the group about harm reduction and the idea, truthfully, the higher up you go in a lot of these systems, the more kind of they are willing to admit that, yes, we are not curing people of their substance use disorder, and we need to take another tactic. So they do allow us to do a peer education program within our facilities that talks about if you do wind up using either, we say we're going to mainly talk about it outside, but obviously all of the information reflects inside as well, about how to use safely, how to potentially wash your needles if necessary, how to safely tattoo. And so all of those things can be done, but it does take a fair amount of education and getting one custody person to kind of be your champion. And I'll stop there.
Thanks, Laura. Anyone else from the panel or SMEs want to follow up on that? Or I see also Rachel has come on camera.
Hi, this is Rachel McLean. I also go by Ray. My pronouns are she or any. I work with the California Department of Public Health. And, about a third, just want to give major props to Dr. Kravietz. I feel like she's being very modest. We've treated many, many thousands of people for hepatitis C in California. The RNA positivity rate has gone down from 20% to 4%, which is really amazing in such a big population. So just want to give props. And also there is a major expansion of medication assisted treatment in our prisons. It sounds like just the uptake is challenging. But what we see from a public health standpoint is that about a third of our acute Hep C cases that are reported in California are reported from our prisons. And it's because we have medication assisted treatment and we have hepatitis C treatment, but we don't have access to sterile syringes or sterile tattooing equipment. And if you look at the modeling studies that have been done in Australia about Hep C elimination, you need all of the legs of the stool. You can't really treat your way out of it. In terms of the questions for CDC, I think in California, the way that we got condoms into our prison is that it was treated like a pilot, where you do a pilot study and you evaluate it. And so I wonder whether maybe NIH could put out, like a funding opportunity to study, pilot and study the effectiveness of safe tattooing in a prison setting, or study a safe injection program, where we give out sterile syringes, because there are programs all over the world that have syringe exchange in their prisons. There's never been anybody stabbing anybody. People are really grateful for the service. So maybe that could be an opportunity to think about. And then there were a lot of questions in the chat about jails. And I put I typed some answers, but just want to say that there are some programs that are able to use 340B drug pricing in their jails in partnership, like with local hospitals. It's challenging because a lot of jails have for-profit providers who are not eligible for 340B, but CMS has been inviting states to apply for 1115 waivers. California has one where 90 days before release, people from prison or jail, people are going to be eligible for pre-release services, which can include testing and treatment. Right now, it's very theoretical. It's just being kind of planned to roll out in 2024 to 2026. I think it remains to be seen how practical it will be, honestly. I think it will be most useful for people who are serving long sentences. Certainly somebody who's in and out in a couple of days, it's not really going to work. But, if someone's serving like a year or 9 months, then it could be feasible. Thanks.
Ray, I'm so glad that you brought up the point about 340B as well as 1115 waivers, because obviously that's one of the most common questions that we get when we talk about providing hepatitis C services in departments of corrections and other correctional facilities is, how do we pay for this? And there were even some questions that came through the chat about, these are folks who lose insurance coverage upon incarceration. Are the costs of treatment passed down to them? There were some questions around Indiana. How did you get some money in your state budget to pay for this care? And so 340B, I think, was mentioned by most, if not all, of our speakers today. And so I think it would be helpful to spend just a moment on that topic because it's a really complex one, right? And I think it would be helpful for people to understand what did you find useful in establishing your 340B partnerships? Were there people, were there resources, partnerships that were critical to standing up a 340B program? And then certainly on the topic of 1115 waivers, which again may be a newer avenue to pay for hepatitis C services for people who are incarcerated, I will drop a link in the chat to a webinar and some slides that we did on this topic a couple of months ago. But curious if anyone would like to comment on 340B.
So Deb from Indiana, I was over at the Indiana Department of Health when Department of Corrections set up their 340B program. What I do know is it is very complicated, as you said. So we used some of the national consultants to make sure that we at the health department were having what we needed, like in our in-kind MOU, to make sure it was written appropriately and that we had all of that covered. At Department of Correction, now we use a consultant. So Anuko Jules comes and does mock audits with us. They make sure that everything is set up appropriate and making sure that we're following all of the regulations that are involved in 340B. My colleague, the executive director of physical health, is the one who actually handles all of that. So as the epidemiologist over here in public health, luckily, they're handling all of that over in finance and physical health. But I can get more information. And I know that they just did a presentation at the American Correctional Association conference, so I can get that PowerPoint as well, if anyone's interested. They presented on it there.
Thanks so much, Deb. So Deb has offered herself up as someone to connect folks to other folks who have been involved in standing up the 340B program. I'm a pharmacist by training, and 340B is both a really important part of our safety net and the bane of my existence as a pharmacist because it is one of our most complex federal programs. And so super, super important to find experts who can help guide you through the process if this is something that your jurisdiction is interested in undertaking. I will also just point that Isabel put in the chat a new resource from NASTAD about standing up 340B partnerships in the chat.
Wonderful. Oh, Amy, go ahead.
I was just going to comment that one of the things that helped us, it was very big and complicated, and our pharmacy has taken the enormous heavy lift on it. But and when we started with HIV medications to start to generate the discount, and once we had generated some money that we could put back into the program, we actually used some of that money to get more pharmacy support to be able to have the infrastructure to be able to expand 340B in a circular fashion, so that, the more money we made, the more people we bought a big program to handle all the data and things like that, so that now we can try, once we have that in place and people to do the monitoring and the audits, and then you're able to do more and more and maybe cover more and more patients. It's all the tracking and monitoring is just massive. So that was something that worked for us.
Thanks for sharing that, Amy. So actually, I wanted to take advantage of, we have some of the brightest minds in corrections and Hep C here. And so Risha mentioned earlier the National Hepatitis C Elimination Initiative that Francis Collins and others are leading and trying to get across the finish line. And we, of course, really see corrections, as I've mentioned in my earlier talk, as a real important place to get this right. But certainly, like you've heard from other presenters, just providing free DAAs is not enough. And so I would, I heard from Rachel or Ray saying, hey, why don't we try and some harm reduction in the settings? What other ideas do you have that the federal government could do to improve the implementation or research or anything else to accelerate hepatitis C elimination and corrections? And Amy, go ahead. Your hand's up first.
Well, I've just been working lately on trying, and I will admit that I'm very novice at getting into the information that's out there. So maybe I'm just uninformed. But the whole idea of smoking and the glass pipes, and it's kind of a materials science issue, that if we can have something that's hot that wouldn't be glass, it would be so much less of a barrier for prison systems to be able to hand out smoking supplies. But I might be uninformed, but it's some research in that department, or even something showing that the patients like these and they would use them, and that it lowered IDU. Might be some research that could be really helpful for us trying to break into this access to clean needle, and smoking pipes and the like issue.
That's a really interesting idea. And just for the audience's background, can you mention a little bit about the harm reduction approach of transitioning from injection drug use to smoking?
For me?
Yeah, or anyone.
Well, I think maybe people in the East might have more experience. I learned that the East is way ahead of California on this. We still have a really, really robust IDU problem inside our prisons. I was interested when I learned that some of the prisons on the East didn't have the same problems because they were smoking. That started my brain thinking, well, how can I, not that I want to advocate for bad lungs, but it's so I I have been trying to figure out how to, get buy-in and try to break down some of the barriers. And I saw that there was just like this, so many different supplies, and they're doing all these things with foil. And so there's got to be a way that we can formalize this into something that we can hand out, is what I was thinking. So I would defer to the other members if they have experience with launching a smoking program.
Not seeing anyone jumping up. So that seems like it's a thread perhaps worth us exploring a little bit, because it is exciting and novel and potentially more palatable than syringes. To the rest of the panel, what else? What else do you think the feds need to hear that we need to, like, how best can we help you from where you sit?
I just have one comment, and that, and just from my perspective, I hear and I'm speaking of someone who had a substance use disorder and has been incarcerated right now, myself, and incarceration served as a really valuable time for me, and that I was able to separate myself from the substances that had overwhelmed my life for a long time. And I think we're remiss if we forget that that is a benefit for many people who are incarcerated, and that we continue to still have a lack of resources for just substance use treatment, generally speaking. And it seems like it just seems, maybe it's just my perspective, but it seems like there's a tension between the different schools of thought when it comes to substance use treatment. There's a harm reduction camp that really wants to push harm reduction. You have a camp of people that really want to push medication, but where's the camp that's really going to look out for people's mental health, their emotional health, their spiritual health, and even their understanding of needing a trade, and that poverty is a huge issue in this as well. So how can we look at this holistically, not just narrow in on one topic and create a system where the solutions are kind of opposed to each other? I think that we need to move into a brave new world where abstinence programs, medication use therapies, and harm reductions, that we can all work together without one thinking the other is worse or better. And I think until we can do that, we're going to just continue around and around in a cycle where we don't see a real improvement.
Daniel, I'm so glad you said that, because, something that we hear all the time and that we kind of try to practice all the time with our navigation program is, of course, Hep C treatment is important to us, right? But it's more important to listen to the person and have them tell you what is important to them right then. And I think you hit the nail on the head with that. And so it made me think about, somebody reached out to me recently. His name is Dr. William Arnold. He is a person who was formerly incarcerated, wrongfully convicted, so his sentence was overturned. He was appointed by our governor. He's in the Office of Workforce, in the Division of Labor and the Office of Workforce Development. And what he is doing is having these monthly meetings where persons who have been incarcerated can come, and there's tables set up. So if you're trying to find a job, if you're trying to find, how to access an SSP, if you need mental health services, just like a one-stop shop kind of the different things, and really allowing that person to decide today, what is the most important thing for me? And if you can build that trust, then they'll come back, and next time it might be something different. And eventually we will get to Hep C treatment, but it's just so important. We can't dictate or decide. We have to ask and we have to listen. And that's just something that he's doing that I think is really innovative. And it's been really eye-opening and beautiful to watch, quite honestly.
Thanks so much, Lindsey. Any last comments before I wrap us up and then close us out for the day?
I was just going to add to, I mean, I know many of you on the phone, but I'm lucky enough to live in a state, right, where I got rehired back to our DOC to do a Hep C test and treat program, and with a goal of Hep C elimination within our prison system, hopefully within the next 5 years. But I understand that other states are not as lucky to have that support. And I think one of the issues is there's such a variation in the relationship between public health and corrections. And in many places, and talking about what can the feds do, is in many places that is not going to happen unless it is somehow incentivized or required of our public health system to get involved. And so to me, that is the most important thing, is I don't think many states that I talk to, public health does not understand even the difference between a jail and a prison, let alone have a relationship. And so unless we kind of make corrections an important part of our public health system, you know, Oregon and hopefully soon Washington and other states now have a correction specific person in their Department of Health, but I think that's rare, and it should not be. And I'll stop there.
Thank you so much. This has been a fantastic session. Thank you all for sharing your time and more importantly, your expertise with us. You know, the overarching theme of this 2-day conference was providing hepatitis C care in high impact settings. But as you can see, both from this session and our session earlier today, it also means providing care in highly complex settings. And correctional facilities are a perfect example of that. And so this has been a really rich discussion. I mean, there are so many pieces to this very complicated puzzle. You know, there are operational considerations. Just how do you get medication to someone in a correctional facility, right? How does it need to be packaged? Do they have a phlebotomist on site? But then there are certainly also fiscal challenges as well. And then the clinical piece is a whole other can of worms, right? So this is a really complicated topic. And you all are doing such important work in trying to answer our healthcare system's most pressing questions and addressing our most pressing needs. So really appreciate all of you for all of the work that you do, for spending some time and sharing your expertise with us. As I mentioned, there were a variety of resources that were shared during today's session. We will ensure that recording gets out to folks and that any of the resources make it to your inboxes as well. But with that, I'm going to turn it over to Daniel to wrap up today and set the stage for tomorrow's session. Thank you all so much.